Hello everyone and welcome to my YouTube channel. This is Dr. Naz and today I'll be discussing about asthma. So what's the asthma? It is a chronic inflammatory and reversible disorder with airway hyperreactivity and variable airflow obstruction. Airway hyperreactivity is the tendency for the airways to narrow excessively in response to triggers that have little to no effect in normal individuals. So there will be a classic triad of wheezing, breathlessness, cough and chest tightness. The episodes have diurnal pattern, that is, the symptoms and lung functions are worse in early morning. So these all symptoms like wheezing, breathlessness, cough and chest tightness occurs more in the early morning. Wheezing during inspiration and especially on expiration is the most common finding on examination. Exacerbations of asthma are associated with tachypnea, tachycardia, use of accessory muscles of respiration, diaphoresis, which is excessive sweating, fatigue, pulsus paradoxicus. Pulsus paradoxicus is decrease in systolic blood pressure by more than or equal to 10 mm of mercury during inspiration. So what are the triggers of asthma or exacerbation of asthma? Respiratory irritants, example smoke or perfume. Allergens, example pets, dust, mites and pollens. Infections like upper respiratory tract infection or sinusitis. Drugs, these are aspirin, NSAIDs and beta blockers. They can exacerbate asthma. Emotional stress, exercise, cold temperature and air pollutants. These all can trigger the airway hyperreactivity. So the diagnosis is made on pulmonary function test, and the pulmonary function test will show obstructive pattern, that is the forced vital capacity will be decreased or normal, forced expiratory volume in 1 second will be decreased, FeV1 to FVC ratio will be decreased, and total lung capacity can be normal or increased. So all the expiratory volumes and capacity will be decreased because there is variable airflow obstructions. What are the diagnostic criteria? We gave a bronchodilator, example albuterol, to a patient and there is increase of FeV1 to more than or equal to 15%. Or after 6 minutes of exercise, the patient had a decrease in FeV1 of more than or equal to 15%. Or there is diurnal variation in peak expiratory flow of more than 20% on more or equal to 3 days in a week for 2 weeks. For 2 consecutive weeks, more than 3 days a week, there is diurnal variation in peak expiratory flow. So these three are diagnostic criteria for diagnosis of asthma. So methacholine challenge test. Methacholine is a bronchoconstrictor and it differentiates between asthma and COPD. In asthma, there is decrease in FeV1 to up to 20%. Therefore, the test is positive. However, in COPD, the test is negative because there is no decrease in FeV1. Other tests include complete blood counts, which will show eosinophilia. Skin testing will identify specific allergens that provoke bronchoconstriction. IgE levels will be increased in allergic etiology as well as allergic bronchopulmonary aspergillosis. So the principle of management includes patient education and avoidance of trigger and early influenza vaccine. The goal of therapy is to achieve complete control. And what do we mean by complete control is daily symptoms of less than 2 times a week, no nighttime symptoms, no limitation of activity, use of reliever medications should be decreased to less than 2 times per week, and normal peak expiratory flow and forced expiratory volume 1. The reliever medications are short-acting inhaled beta agonist, also known as SABA, albuterol example, and short-acting inhaled anticholinergic, example ipratropium. So this is a stepwise management of asthma. Step 1 is for intermittent asthma. We will give inhaled short-acting beta agonist. And step 2 is for mild persistent asthma, and the preferred agent is low dose inhaled corticosteroid along with beta agonist. And the step 3 is those two medications that is step 1 and step 2 plus long acting beta agonist. And in step 4 the dose of steroids is increased to medium dose. In step 5 high dose of inhaled corticosteroids is used. And in step 6 oral corticosteroid is also added. And we follow up the patient after 3 months and consider if we need to step up the treatment or step down the treatment. If there is adherence and still the symptoms persist, then we need to step up the dose. And if this well controlled asthma for at least 3 months, then we will step down the management. So basically the treatment of asthma depends on the severity and the duration of symptoms. For mild intermittent asthma, inhaled short-acting beta agonist on PRN basis is enough, and it is the treatment of choice. The example of SABA are albuterol and terbutaline. So for mild persistent asthma, we use regular preventive therapy. What are the indications of mild persistent asthma? There is exacerbation of asthma in the last 2 years, or the patient is using inhaled beta agonist for more than 3 times a week. The symptoms are there more than 3 times a week, or the patient is awakened by asthma one night in a week. So we will give SABA along with low dose corticosteroid, which is a preferred agent. However, leukotriene receptor antagonist or mast cell stabilizers can be used instead of low dose corticosteroids. So the step 3 is for moderate persistent asthma, and for this we will add on therapy. So along with SABA and low dose inhaled corticosteroids, we can add any of the following drugs, like long acting beta agonist, which is the preferred choice, example salmeterol or formoterol, or we can add long acting anticholinergics, example tiotropium, or we can add leukotriene antagonist, example montelukast, or we can add theophylline. Or if not any of these drugs, then we can simply increase the dose of inhaled corticosteroids. So there are some cautions which we should keep in mind, that long-acting beta agonist can increase peak expiratory flow when added to inhaled corticosteroid. So it should always be combined with inhaled corticosteroids except for exercise-induced asthma. And its monotherapy without ICS is associated with poor compliance and increased risk of exacerbation, also increased mortality, especially in blacks. So for severe persistent asthma, we can do a step-on therapy. So what we will do is we will add SABA plus medium dose of ICS, that is we are going to increase the dose of inhaled corticosteroids with one of the following. So either we will give long-acting beta agonist or long-acting anticholinergics or oral leukotriene or theophylline. So what we have to do is, with short-acting beta agonist and long-acting beta agonist, we have to increase the dose of ICS. So in step 5, for severe persistent asthma, we can give high dose of inhaled corticosteroid. So here the maximum dose of inhaled corticosteroid is used along with SABA and LABA. And omalizumab, which is a monoclonal anti-IgE antibody, can also be considered in step 5. Indicated in severe asthma which is not controlled by the above 5 steps. So in this, the above medications along with oral steroids or anti-IgE therapy is used. So what is the indication of severe asthma? When there are daily symptoms with frequent nocturnal symptoms, frequent emergency room admissions and hospitalization, and when FEV1 is less than 60%. But oral steroids should be used in the lowest possible dose, providing adequate control because of the risk of side effects. And these side effects occur in the patient who are on long-term therapy, that is taking steroid for more than 3 months, or if they are taking more than 3 to 4 courses per year. Acute exacerbation of it is characterized by increased symptoms, deterioration of lung function, and increased airway inflammation. The triggers are viral infection, which is the most common trigger, molds, pollen, and air pollution. So the life-threatening features of acute exacerbation of asthma include peak expiratory flow less than 33% predicted if saturation is less than 92% and partial pressure of carbon dioxide is less than 60%. Normal partial pressure of carbon dioxide is also a life-threatening feature, because in acute asthma there is tachypnea, and tachypnea causes decreased partial pressure of carbon dioxide. However, if there is normal or increased partial pressure of carbon dioxide, it means that the respiratory muscles are fatigued or there is impending respiratory failure. Silent chest is also a life-threatening feature, that is absence of wheezes because of no air movement, feeble respiratory effort, bradycardia or arrhythmia, cyanosis, hypotension, confusion and coma. These all are life-threatening features of acute exacerbation of asthma. So peak expiratory flow is used to follow up the clinical course of the disease, and it is measured in all patients. It should be recorded every 15 to 30 minutes, then every 4 to 6 hours. Arterial blood gases should be measured in all patients. Partial pressure of carbon dioxide is initially low. Normal or high levels suggest respiratory failure or muscle fatigue. So for the treatment, we will give high concentration of humidified oxygen to keep the saturation more than 92%. Bronchodilator should be given. Example, short-acting beta agonist as the first-line agent. It can be given as a metered dose inhaler or via nebulizer. Systemic steroids per oral or IV if impending respiratory failure. Severe asthma needs ipratropium, either metered dosed inhaler or nebulizer. IV magnesium provide bronchodilation in those with decreased peak expiratory flow of less than 30%. Endotracheal intubation if there is severe asthma and patient is in coma, confusion, exhaustion, drowsiness, there is respiratory arrest, ABGs are deteriorating. Example, partial pressure of oxygen is less than 60% and partial pressure of carbon dioxide is more than 45%, and there is acidosis, then we will go for endotracheal intubation. Disposition. So we have to decide disposition within 4 hours of presentation and after 1 to 3 hours of treatment. Good response is suggested by peak expiratory flow rise of more than or equal to 70%, increase in saturation of more than 90%, normal examination and no symptoms. Response maintained 60 minutes after treatment, can be discharged home. Incomplete response include peak expiratory flow of 40 to 69%, mild to moderate signs and symptoms. This should be considered as a candidate for hospital admission. Poor response include peak expiratory flow of less than 40%, partial pressure of oxygen less than 60%, and partial pressure of carbon dioxide is either increased or normal with severe symptoms. Altered mental status, this is a candidate for ICU admission. So this is the end of the lecture. I hope you learned something from it. If you do, please like my video and subscribe to my YouTube channel. Thank you for watching.